All right, so you're getting ready for a nursing lecture on osteoporosis and osteoarthritis.
Oh, and rheumatoid arthritis.
Right, all
Yeah.
those things that can go, right or wrong
Yeah.
with our musculoskeletal system. So today's deep dive should really equip you with like some key knowledge to rock that lecture.
Fantastic.
I'm really excited to have you here because, your insights into anatomy and physiology are just what we need to like unpack these pretty complex conditions.
Right.
So let's kick things off with a little bit of A&P.
Okay.
A little refresher. Bones. We all know they're like, the scaffolding of our bodies, right?
Yeah.
Support, movement, all that good stuff. But maybe something people don't think about so much is that there are actually like two main types of bone tissue.
Yeah. It's so cool how they work together. You have like cortical bone,
Right.
that tough outer layer, giving us that strength. So think of like your femur, like that thigh bone.
Yeah.
Yeah. It's a great example of like cortical bone giving that structure.
Awesome. And then we have like its partner in crime.
Yes.
Cancellous bone.
Cancellous bone. Yeah.
The more porous, like honeycomb-like
Exactly.
structure, and we find those especially at the ends of long bones and in the vertebrae, right?
Yeah. It's like nature's shock absorber.
Ooh.
Pretty neat how that works.
So cool. So we've got this framework, but it needs to like move.
Yeah.
So enter the joint.
Under the joints.
Our I guess most well-known joints would be like synovial joints.
Yeah, like your knee, your elbow.
Exactly.
They allow for smooth movement.
Yeah.
Thanks to that synovial fluid. It's like a well-oiled machine.
I love it. So now that we've got that kind of that base, that foundation,
Yeah.
let's dive into what happens when things don't quite go to plan with the musculoskeletal system.
All right.
So first up, osteoporosis.
Osteoporosis, yeah.
Often called the silent disease, right?
Mm-hmm.
Because you might not even know you have it until you fractured a hip or a wrist or
Exactly, yeah. A vertebra.
Yeah, it's a real concern, especially, as we age, but also specifically, it's a major concern for Canadians over the age of 65.
Yeah, it's interesting how the social determinants of health really like impact osteoporosis. So for women in particular,
Right.
you have to think about things like calcium intake. Also menopause and how hormones play a role.
Right.
Even pregnancy and breastfeeding can impact bone density.
Oh, wow.
And it's particularly important to note that there are a lot of health disparities and a lot of like underdiagnosis and undertreatment amongst racialized women.
So it's not just, those basic factors. There's like a whole lot of other social things going on that influence whether or not you might develop this. So
multifactorial.
Yeah, it's like the perfect storm.
Yeah, sure.
Of factors. So, okay, so we know there's this risk, but what's going on at the cellular level? Like what's actually happening in osteoporosis?
So imagine your bones is like a construction site.
Okay.
And you have crews that are constantly breaking down old bone and building up new bone.
Right.
In osteoporosis, that demolition crew is a bit overzealous.
Okay.
And the construction crew just can't quite keep up.
So it's like that imbalance that leads to like the fragile bone.
Yeah, the fragile bones. And then you see those signs like, back pain, maybe a shrinking stature, or even a stooped posture, what we call kyphosis.
Yeah, so it's like, I don't know, it's like that Jenga tower where you keep taking out blocks.
Exactly.
And then eventually it's going to fall.
Yep.
So we've talked about, age, gender, but what else? Like, what other things could increase your risk of developing osteoporosis?
So, certain diseases like rheumatoid arthritis can increase your risk. Mm-hmm. And, some medications like corticosteroids can actually weaken your bones over time.
Oh, okay.
And then there are those lifestyle factors.
Right.
Like smoking, which is really bad for your bones.
Yeah.
And excessive alcohol.
So these are all things like if you're trying to like prevent osteoporosis.
Exactly.
Those are things you want
to
avoid, or manage. And the scary thing is, bone loss can be significant before you even.
Exactly. It's silent.
Yeah.
Yeah.
So how do we catch it early?
So we have some great tools like, bone mineral density measurements, as well as like fracture risk assessments.
So that can kind of give us a heads up.
Exactly.
Before something bad happens.
Yeah. Early intervention is key.
So, okay, let's talk about, you've been diagnosed with osteoporosis. What are some things you can do to kind of, fight back?
So, calcium and vitamin D are like the building blocks for strong bones. So making sure you're getting enough of those through diet or supplements is super important.
Awesome. And what about like lifestyle changes.
Yeah, so things like, weight-bearing exercises, like brisk walking, jogging, dancing, all of those are fantastic.
It's like sending your bones to boot camp.
Yes, exactly.
Right.
And then, of course, eliminating those bad habits like smoking and excessive drinking.
And then there's medications as well, right?
Yeah, so medications are kind of like those reinforcements for that struggling bone-building crew.
Okay.
So, like bisphosphonates are commonly prescribed.
Mm-hmm.
But of course, there are other options, and it's really important to, work with your healthcare provider to find what's right for you.
And tailor that treatment plan.
Exactly.
Awesome. Now, we did talk about fractures, but I think hip fractures, especially for like women over 75.
Yeah, they're really serious.
They're really serious. Like, it's not just, oh, you broke a bone. Like, it can be really life-altering.
Exactly. And a lot of the times they're a direct result of osteoporosis.
Yeah.
And it's really important to, like, have that surgical intervention quickly to improve outcomes.
And there are different surgical approaches too, right?
Yeah. So it depends on like the fracture and the person's health.
Okay.
So you have things like, open reduction internal fixation, which uses things like a gamma nail for stability.
Yeah.
But you also have things like a hip hemiarthroplasty, which is just replacing the ball of the hip joint.
Interesting. So it really depends on the situation.
Exactly.
All right. So let's switch gears completely.
Okay.
And talk about, well, a totally different beast, rheumatoid arthritis.
Yeah, rheumatoid arthritis.
So this is a chronic autoimmune disease.
Yeah.
Where it's basically like your body is attacking its own joints.
Exactly. And it's this constant cycle of like flares and remissions.
Yeah.
So it can be, it varies over time.
Yeah, so it's not kind of a constant thing. It's it comes and goes.
Exactly.
So what's happening like inside the body to kind of cause this?
So think of like a healthy immune system, right?
Sure.
You've got soldiers and they attack the foreign invaders.
Okay.
Like bacteria or a virus. But in rheumatoid arthritis, some of those soldiers go rogue.
Uh-oh.
They decide that the synovium, the lining of the joints, is the enemy.
So it's like friendly fire.
It's like friendly fire.
Yeah.
Yeah, and this attack triggers this cascade of inflammation.
Right.
Which releases all these chemicals, and they start to damage the cartilage and the bone, which then leads to all that pain, swelling, and stiffness.
So if you were like, living with rheumatoid arthritis, like what would you be feeling? What are the signs?
So early on, you might notice like fatigue, unexplained weight loss. Maybe you're not feeling so great, just kind of run down.
Mm-hmm.
But as it progresses, those joint symptoms become more prominent. So you're going to feel that pain,
right?
The stiffness. You're not going to be able to move as well.
Yeah.
And then you have those classic signs of inflammation.
Right, like the heat and the
heat, the swelling, the tenderness.
And it typically affects like joints symmetrically, right?
Yeah. So that's one of the like hallmarks of rheumatoid arthritis. So if you have like, in one wrist, you're probably going to have it in the other wrist.
Right.
And it often starts like in the small joints
of
the hands and the feet. So like, your fingers, your toes. But it can then progress to the larger joints.
Okay, so like your knees.
Knees, elbows, hips, even the jaw.
Oh, wow.
Yeah.
And there's that, I always think about rheumatoid arthritis. I think about like that morning stiffness.
Oh, yeah.
It's like, you wake up and you just can't.
Yeah, it's like your joints are rusted shut.
Yeah, exactly.
And it takes a while to get going.
And so as the disease progresses, can it lead to like more serious problems?
Yeah. So unfortunately, over time, that chronic inflammation can actually damage the cartilage and bone, leading to like deformities, disability. You can have muscle atrophy, even tendon destruction. So imagine, your fingers drifting sideways or bending in kind of unusual ways.
Right. So it can really impact your ability to do like everyday things.
Absolutely. Yeah.
So early diagnosis and treatment, I'm guessing, is really
super important here
to try to halt that damage.
Yeah. So what do we do? Like, how do we manage this? Because it sounds like a really complex condition.
Yeah, it definitely is. So it's a multi-pronged approach involving medications, lifestyle modifications, and then supportive therapies. So first of all, nutrition plays a huge role.
Okay.
Focusing on those anti-inflammatory foods to kind of calm the internal battleground, if you will. But, joint protection is also key. It's like, give your joints a break.
Right.
Balance activity with rest. Yeah. use splints if you need to.
Right.
And adapt your daily activities to just minimize strain on your joints.
And I imagine exercise is still important, but you probably have to be a bit more careful.
Exactly. So we want to keep those joints moving but gently.
Right.
So things like, swimming or cycling, those are great.
Okay.
And, working with a physical therapist is always a good idea to kind of come up with a personalized plan.
Okay. Now let's talk about medications.
Okay.
Because this is a whole world.
Yeah, it's a whole world.
Of different.
Yeah, so you have things like, disease-modifying anti-rheumatic drugs or DMARDs, which are kind of like the frontline soldiers trying to slow down the progression of the disease.
Right.
So, methotrexate is a classic example. And then you have these biological response modifiers, or BRMs.
Okay.
Which are more like precision-guided missiles.
Okay.
Targeting specific components of the immune system to kind of dampen that inflammatory response.
So it's like choosing the right weapon exactly for the right battle.
Yeah, yeah.
I love it.
And then you have corticosteroids, which are like those powerful extinguishers for those inflammatory fires.
Okay.
But they're usually used for a short amount of time.
Right.
Because of their potential side effects.
Yeah, yeah.
And then, of course, you have NSAIDs like ibuprofen or naproxen, which can also help with pain and inflammation.
So it's a lot to kind of consider.
It is.
When you're, thinking about managing this.
It's individualized.
Yeah.
Absolutely.
So, okay, last but not least, osteoarthritis.
Okay, osteoarthritis.
So the most common type of arthritis affecting millions of Canadians.
It is.
It's often called like wear and tear arthritis.
Yeah.
But I think it's a little bit more nuanced.
Yeah, it is.
Than just,
It's not just your joints wearing out. It's really this complex interplay of, genetics, metabolism.
Right.
Even those like little injuries that your joints experience.
And the more time over time. Yeah.
So what are some of the like triggers? Like what are some things that can kind of set the stage for osteoarthritis?
So some medications can actually speed up that cartilage breakdown.
Okay.
So, things like gout medications or even corticosteroids.
Corticosteroids again?
Yeah, they can be a bit of double-edged sword.
Right.
And then, hematological disorders where there's bleeding into the joints.
Okay.
That can damage the cartilage over time.
Interesting. So it's like kind of one problem can lead to...
It's a domino effect.
Yeah.
Yeah. And then, of course, joint instability. So if those ligaments and tendons get stretched or torn,
right,
that can put uneven stress on the cartilage and speed up that degeneration.
It's so interesting how, like, it's not just wear and tear. Like, all these other factors can kind of...
multifaceted, for sure.
What about like mechanical stress? Like what is that?
So, those repetitive movements. So, if you play certain sports or if you have a job where you're...
Right, you're doing the same motion over and over.
Exactly. That can definitely take a toll.
Yeah. So, okay, so let's walk through like the actual pathophysiology of osteoarthritis. Like what's happening in the joint?
So imagine the cartilage in your joint is like a smooth, slippery surface.
Okay.
It allows your bones to glide past each other. In osteoarthritis, that surface gets rough and worn down.
Okay, so that nice, smooth surface is...
It's not so smooth anymore.
Yeah. So it's like the kind of the cushioning.
Exactly. The cushioning breaks down. The joint space narrows.
Right.
The bones start rubbing against each other.
Ouch.
Yeah, it's not comfortable.
So that leads to, I'm guessing, the symptoms of like pain?
Yeah, pain is a big one.
Yeah.
And it's usually described as like a deep aching pain.
Okay.
And it's worse with activity, and at least initially, it's relieved by rest.
Oh.
But as it progresses, the pain can become more constant, even disrupting sleep.
Right. So it can be like really debilitating.
Yeah.
And you mentioned stiffness earlier.
Yeah. So stiffness, especially after like you've been resting.
Yeah. It's like you wake up in the morning and you're...
Yeah. It's like those westy hinges.
Yeah, exactly.
And there's this grating or crackling sound.
Right.
When the joint moves.
I always think about that with osteoarthritis. I think about that like that sound.
It's called crepitus.
Yeah.
And it's basically just those roughened bone surfaces rubbing together. Yeah.
Now, unlike rheumatoid arthritis, osteoarthritis tends to be more asymmetrical.
Yeah. So you might have it in one knee, but not the other.
Oh.
For example.
Okay.
And you also get those characteristic deformities like Heberden's nodes.
Right. Those are those bony
enlargements on the finger joints.
Uh-huh.
And then you have Bouchard's nodes.
Which affect kind of the middle joint of the finger, right?
Exactly.
Yeah. And then you mentioned, like, you might see, like, bow-leggedness or...
Yeah, so in the knees, you might see a varus deformity, which is bow-legged.
Okay.
Or a valgus deformity, which is knock-kneed.
So those are kind of like as it gets...
Yeah, more advanced.
Yeah.
You might see those things.
So given all of this, like, it's, this wear and tear, what can you do to kind of manage it?
So there's no cure for osteoarthritis, unfortunately.
Okay.
But the focus is really on managing those symptoms.
Okay.
Slowing down that progression and maintaining and improving that joint function.
Okay.
So it typically starts with things like rest, joint protection,
Right.
and medications to manage that pain and inflammation.
So it's, again, that balance, right?
Yeah, it's all about balance.
It's like you want to keep your joints moving, but you don't want to, like, overdo it.
Exactly.
And then heat and cold therapy, is that helpful?
Yeah, so both heat and cold can be really beneficial.
Okay.
So heat can relax those muscles and increase blood flow, while cold can reduce inflammation and numb the pain.
Okay.
So it's like using different tools.
Right, for different
jobs.
Yeah. And then what about, like, the role of nutrition and exercise?
So if you're carrying extra weight, those weight-bearing joints are under constant stress. So even losing a small amount of weight can really make a big difference.
Okay.
And exercise is really important.
Yeah.
To maintain that strength, that flexibility, and that range of motion.
So you're not, like, you're not trying to run a marathon, but you're still trying to keep those joints.
Yeah, keep them lubricated and moving.
Yeah. What about, like, acupuncture or supplements? Like, do those things have a role?
So while some people might find relief from those therapies, it's really important to be cautious.
Okay.
To make sure that they're evidence-based, and always discuss those therapies with your healthcare provider to make sure that they're right for you.
Awesome. And then the world of medications for osteoarthritis.
So, for mild pain, we often start with acetaminophen.
Okay.
And then topical creams containing, NSAIDs or capsaicin, which is what makes chili peppers hot.
Oh, interesting.
It provides some localized relief.
And then for more kind of moderate to severe pain.
Yes. So then you've got your oral NSAIDs.
Yeah.
But we know those can have side effects.
Right.
So you have to be a bit careful with those, especially if you're taking them long term. And then sometimes we use corticosteroid injections directly into the joint.
And that can provide
temporary relief
Okay.
from the pain and the inflammation.
So what happens when, like, you've tried all these things and it's not working? Like, what are the other options?
Yeah. So if the pain is really severe and it's limiting your daily activities, or if the joint damage is really significant, then joint replacement surgery or arthroplasty might be recommended.
Okay, and those are most common for hips and knees, right?
Yeah, those are the most common.
Yeah.
But they can also be done on other joints, like shoulders, elbows, even fingers.
So the goal being, like, basically to kind of, take that joint that's not working.
Exactly.
And just, like...
give you a new one.
Yeah, get a new one.
Yeah.
So you can get back to doing the things you love.
Exactly.
Awesome. So we have covered a lot of ground.
We have.
From basic bone anatomy to the complexities of all these conditions.
Yeah.
And we're not done yet.
We're not done yet.
We have more to explore, including some NCLEX style questions and case studies to really put that knowledge to the test.
Oh, I love a challenge.
So let's take a quick break and then we'll dive right back in.
Sounds great. It's interesting because as we're kind of unpacking all these conditions, it's not just about the physical stuff.
Yeah.
Right. It's really important to think about, like, the person behind the disease and how these conditions can kind of have this ripple effect on their mental health, their relationships, their ability to work, even enjoy hobbies.
Totally.
So imagine, like, someone with severe rheumatoid arthritis.
Okay.
They're dealing with chronic pain. They're stiff. They maybe even have joint deformities, right? So it's not just like a physical thing.
It's an emotional thing.
It's emotional too. It's the frustration. It's the limitations. It's the, like, feeling trapped in your own body,
And as a result, like, their world just starts to shrink.
Exactly.
Yeah.
And then you think about someone with osteoarthritis. As that pain gets worse, maybe they have to give up activities they love.
Yeah.
And that can lead to, like, a sense of loss or isolation.
And even for someone with osteoporosis, that fear of falling.
Oh, yeah.
Like, that can be so...
it's debilitating.
Debilitating. It's like they're afraid to, like, leave their own home.
Exactly.
Because they're worried about, like, fracturing a bone.
Yeah, their world becomes kind of this minefield of like potential fracture.
Yeah, so these are all like really important things to think about, that it's not just about the physical.
Each person.
Yeah.
Absolutely.
So now your nursing lecture actually highlights the importance of kind of these focused musculoskeletal assessments.
Yeah.
So can you kind of walk us through, like, what does that actually look like?
So, it's like you're a detective, right?
Yeah.
You're searching for clues to understand what's going on with that person's musculoskeletal system.
I like that.
Yeah.
So what are some of those clues?
So first of all, you got to start with a really good history.
Okay.
So we ask them about pain, stiffness, any limitations in their movements, any past injuries they've had, their overall health, all of those things.
So it's like gathering like all those puzzle pieces.
Exactly. And then we move on to the physical exam.
Okay.
So we observe their posture, how they walk, how they move their joints. We carefully palpate the joints, so we're feeling for any tenderness, swelling, warmth, and checking their range of motion.
Okay. Are there any like kind of special techniques or like tests that nurses use to assess for like specific problems?
Oh yeah, we have some pretty cool tricks.
Okay, I like it.
So for example, if we suspect that there's fluid in the knee joint, we might use something called like the bulge sign.
Okay.
Or ballottement of the patella.
Okay, break those down for us.
Okay, so imagine like the knee joint is a water balloon.
Okay.
If there's fluid inside,
yeah,
and you press on one side, you're going to see a bulge appear on the other side.
Oh, so it's like visually you can see
It's a visual clue
that there's something going on.
Exactly.
Okay.
And then ballottement of the patella is kind of like bouncing a ball.
Okay.
So we push down on the kneecap, and if it bounces back against our fingers, it suggests there's a lot of fluid in there.
Oh, wow. So it's like these simple little tests can actually...
Yeah, they can unlock a lot of information.
Yeah.
Yeah.
Awesome. So I know that your nursing lecture also includes some like NCLEX style exam questions. So I thought it would be fun to kind of put your knowledge to the test a little bit.
I'm ready. I love a challenge.
Okay. So first question, which of the following are functions of bone? And you can choose multiple answers. So support, movement, production of hormones, protection of internal structures, blood cell production.
Okay, so I know bones definitely provide support.
Okay.
Right? They allow us to stand upright and move. They protect our internal organs like a suit of armor. And then I remember learning that blood cell production happens in the bone marrow. But hormones, I think that's more of an endocrine system thing.
You are absolutely right. So bones are not involved in hormone production.
Okay, good to know.
That's the job of those specialized glands.
I almost fell for that one.
It's a common misconception. Okay, so next question. What type of bone makes up approximately 80% of the human skeleton? So is it cancellous, compact, trabecular, or spongy?
Okay, so I remember cancellous, trabecular, spongy, all kind of refer to that, like porous inner layer. So it has to be compact bone, which is that dense outer layer.
You are correct. Compact bone, also known as cortical bone,
yeah,
is the workhorse of the skeleton.
It gives that structure.
Yeah.
Yeah.
Okay, 2 for 2.
2 for 2.
All right, let's keep this momentum going.
Okay.
A patient diagnosed with osteoporosis is most likely to experience which of the following clinical manifestations? And again, you can choose more than one. Spontaneous fractures, joint swelling, loss of height, back pain, decreased range of motion.
Okay, so with osteoporosis, we know that the bones are weakened, so they're more susceptible to fractures, even from like a minor trauma.
Right.
And as the vertebrae kind of weaken and compress,
yeah,
that can lead to loss of height and back pain. Joint swelling and decreased range of motion, I think those are more typical of inflammatory conditions.
Right.
Like rheumatoid arthritis.
Yes, you are absolutely right. You've nailed it.
Okay, good.
Okay, which of the following are common risk factors for developing osteoporosis? Female gender, age over 65, smoking, high calcium intake, long-term use of corticosteroids.
Okay, so we know women are at higher risk, especially after menopause because of those hormonal changes. And then age is a big one.
Right.
As we get older, our bones naturally start losing density.
Yeah.
Smoking is a big no-no for bone health.
Yep.
And long-term use of corticosteroids can interfere with bone metabolism. But high calcium intake, that should be protective.
You are spot on. High calcium intake is like one of the things you want to do.
Exactly.
To prevent osteoporosis.
Yeah, to build up those bones.
Exactly.
Right.
All right. Which assessment technique is used to check for small amounts of fluid in the knee joint? So, ballottement of the patella, bulge sign, McMurray's test, or drawer test?
Okay, I remember we were talking about this before. So ballottement is for larger amounts of fluid.
Mm-hmm.
McMurray's is for meniscal tears. And the drawer test is for ligament stability. So it has to be the bulge sign.
Yes.
Yeah.
You've got a great memory.
Okay.
It's that subtle little bulge when you press on the knee. Okay, ready for a true or false?
Hit me with it.
True or false, cancellous bone is denser than cortical bone?
Okay, so cancellous bone is all about shock absorption.
Mm-hmm.
It's that lightweight support.
Mm-hmm.
Cortical bone is that, like, tough outer layer that gives the bone its strength.
Yeah.
So cancellous bone can't be denser. The answer is false.
Correct.
Yes.
Okay, you're on a roll.
All right.
Which joint is most commonly affected by osteoarthritis? So is it the shoulder, the elbow, the knee, or the hip?
So osteoarthritis is often called wear and tear arthritis, right? Mm-hmm. So it would make sense that the joints that bear the most weight would be the most susceptible. So I'm going to go with knee and hip, probably a close second.
You were absolutely right.
Okay.
So those weight-bearing joints...
They work hard.
They do.
Yeah.
Okay, what is the primary pathophysiological process in osteoporosis? So is it increased bone resorption, decreased bone formation, inflammation of joint tissues, or cartilage deterioration?
Okay, so osteoporosis is all about that imbalance between bone breakdown and bone building.
Mm-hmm.
And we know that bone resorption, which is the process of breaking down bone tissue, is kind of out of control in osteoporosis.
Yeah.
So the answer is increased bone resorption.
You got it.
Okay.
It's like that demolition crew working overtime.
Exactly, and the construction crews just like...
They can't keep up.
Yeah, they're slacking.
All right, true or false? Osteoporosis primarily affects men more than women.
False. It's women, especially after menopause.
You are correct.
Yes.
It's those hormonal changes.
Those hormones. They're tricky.
Okay, in rheumatoid arthritis, which of the following symptoms is expected? And again, you can choose more than one. Morning stiffness, joint deformities, asymmetrical joint pain, fatigue, low-grade fever.
Okay, so morning stiffness is definitely a classic symptom.
Mm-hmm.
Joint deformities can develop as the disease progresses.
Right.
And then fatigue is a common complaint because your body's constantly like fighting that inflammation.
Right.
And then low-grade fever, I think that can happen too.
Yeah.
Especially during those flare-ups.
Yeah, you hit all the key points there.
Okay, good.
Remember, rheumatoid arthritis, it's a systemic disease, so it can affect the whole body, not just the joints.
Right.
So those kind of systemic symptoms like fatigue and fever, those can be part of the picture.
Yeah, it's not just localized.
Yeah. All right, last question in this round.
Okay.
Which assessment technique is used to check for small amounts of fluid in the knee joint? So ballottement of the patella, bulge sign, McMurray's test, or drawer test?
Okay, I think we talked about this one before. So ballotment's for larger amounts of fluid.
Right.
McMurray's is for meniscus tears, and drawer test is for ligament stability. So it has to be the bulge sign.
Yes. You remembered it's that subtle little bulge.
Little bulge, yeah.
Okay, fantastic. So let's take a look at some of those case studies and application questions from your nursing lecture. So these are really going to kind of test your ability to apply what we've learned to real world situations.
Right.
So first scenario, a 70-year-old female presents with a fractured hip. What is the priority nursing intervention? So administer analgesics, prepare the patient for surgery, assess for neurovascular status, or initiate physical therapy.
Okay, so a fractured hip, especially in an older adult, that's a really serious injury. So while pain management is important, I think the top priority would be to assess for neurovascular status.
Okay.
Just to make sure that there's no damage to the nerves or blood vessels in that leg.
You are absolutely right. So you want to make sure that there's adequate blood flow, that the nerves are functioning properly.
Exactly.
So checking pulses, sensation, color, temperature, all those things.
Yep, all of that.
And then, I'm guessing, preparing the patient for surgery.
Yeah, because most hip fractures require surgery to repair them.
And then pain management would be kind of an
ongoing priority.
Yeah.
Definitely.
And physical therapy, that would come later?
Yeah, later on, during rehab.
Okay, so it's a kind of like a
triage system.
Yeah, like you got to...
What's most important.
Yeah, prioritize.
Yeah.
All right, which laboratory values would be important to monitor in a patient receiving methotrexate for rheumatoid arthritis? Liver enzymes, complete blood count, CBC, electrolytes, blood glucose.
Okay, so methotrexate is a pretty strong medication.
Yeah.
And it can have side effects.
Right.
I know it can affect the liver, so monitoring liver enzymes is super important. And it can also suppress bone marrow function, so a complete blood count is essential to check for, like anemia, low white blood cells, things like that.
Yeah, so those are the big ones.
Those are the big ones.
The electrolytes and blood glucose are important to monitor generally.
Yeah, in general.
But not specifically related to the methotrexate.
Yeah.
Okay, true or false? Weight-bearing exercises can help prevent osteoporosis.
That's true.
Yes.
Weight-bearing exercises like walking, jogging, dancing, they all put stress on the bones.
Right.
And that actually stimulates them to become stronger and denser. It's like weightlifting for your skeleton.
I love that analogy.
Yeah.
It's like you're giving your bones a workout.
Exactly.
Awesome. Okay, what teaching point is essential for a patient starting bisphosphonates for osteoporosis? Take with food for better absorption, remain upright for at least 30 minutes after taking, discontinue if gastrointestinal upset occurs, or take at bedtime for better results.
Okay, so I know bisphosphonates can be a bit rough on the stomach.
Okay.
They can cause like irritation and ulcers. And I remember reading that you have to take them on an empty stomach with plain water to enhance absorption.
Right.
So taking it with food wouldn't be good.
Yeah.
But I'm not sure about the other options.
Okay, so the key point here is to remain upright for at least 30 minutes after taking them.
Okay.
Because they can actually irritate the esophagus if they don't go straight down to the stomach.
Oh, I see. Okay.
So staying upright helps prevent that reflux.
Okay, so it's not about the absorption. It's about
Preventing that.
preventing it from coming back up.
Yeah, exactly.
Right.
And GI upset is a common side effect, but it's usually manageable.
Yeah.
But you wouldn't want to just discontinue the medication without talking to your doctor.
Right.
Okay, which of the following medications is classified as a DMARD? So is it ibuprofen, methotrexate, prednisone, or etanercept?
Okay, so ibuprofen is an NSAID. Prednisone is a corticosteroid. Etanercept is a biological response modifier. So it has to be methotrexate.
Yes.
The classic DMARD.
You're getting the hang of these medication classifications.
I know, right? It's starting to make sense.
Awesome. Okay, true or false? Osteoarthritis is characterized by systemic inflammation.
Okay, so osteoarthritis is mainly a degenerative joint disease. It's not an autoimmune condition like rheumatoid arthritis.
Right.
So I'm going to say false.
You are correct.
Okay.
So osteoarthritis can cause inflammation.
Yeah, in the joint.
But it's not like this whole body.
No, it's not systemic.
Yeah, it's not like everything.
Exactly.
All right. In which of the following scenarios would a nurse prioritize a musculoskeletal assessment? So, a patient with chest pain, a patient with a history of falls, a patient reporting joint stiffness, a patient scheduled for a hip replacement.
Okay, so chest pain, that would require a cardiac assessment, right? That's the priority.
Yes.
But a history of falls, joint stiffness, and a patient scheduled for a hip replacement.
Yeah.
I think those would all warrant a musculoskeletal assessment.
Yeah, those are all red flags.
Red flags.
Yeah.
Got to watch out for those.
Okay, true or false? Osteoporosis can be diagnosed accurately with x-rays alone.
Okay, I remember learning that bone loss can be significant before you even see it on an x-ray.
Right.
So I'm going to say false.
You are correct.
All right.
X-rays can show fractures, but they can't really pick up that early bone loss.
Okay.
So what do we use?
So what's the gold standard?
Bone mineral density testing.
Okay.
Often using a DEXA scan.
DEX scan. All right.
Okay, the presence of Heberden's nodes is indicative of which condition? Rheumatoid arthritis, osteoarthritis, osteoporosis, or gout?
Heberden's nodes, those are the bony enlargements on the finger joints, right?
Yeah.
We were talking about those earlier.
Yeah.
That's osteoarthritis.
Yes. You've got a great memory.
I'm trying.
Okay, what are the goals of treatment for osteoarthritis? So, reduce pain, prevent disease progression, increase joint flexibility, or promote weight gain.
Okay, so we know there's no cure, so it's all about managing the symptoms, slowing down that progression. Reducing pain is definitely a top priority.
Yeah.
Increasing joint flexibility is also important for function, but promote weight gain. I don't think that's beneficial.
No, that would actually make things worse.
Yeah, especially for those weight-bearing joints.
Exactly.
Yeah.
Especially if you're thinking about the knees and the hips.
Exactly, yeah.
Okay, a nurse is caring for a patient with rheumatoid arthritis experiencing a flare-up. Which intervention should be prioritized? Encourage vigorous exercise, administer prescribed anti-inflammatory medications, suggest increased dietary calcium, or provide hot compresses to the joints.
Okay, so doing a flare-up, inflammation is the enemy.
Yeah.
So I would say administering those prescribed anti-inflammatory medications.
You are absolutely right.
Okay.
Those anti-inflammatories, those are like the go-to
Yeah,
during a flare-up.
for sure.
They help get that inflammation under control.
Yep.
Okay, true or false? Social determinants of health can impact the incidence and treatment of osteoporosis in racialized women.
So we talked about this earlier. Things like access to healthcare, socioeconomic status, even discrimination. They can all really impact health outcomes. And we know that racialized women are at higher risk for osteoporosis, and they often face disparities in diagnosis and treatment. So the answer is true.
Yes, you're absolutely right.
Okay.
It's a reminder that, healthcare is about more than just biology.
Yeah, it's complex.
Yeah, all those social factors.
Social factors.
A patient with rheumatoid arthritis is being educated about the disease. Which statement indicates a need for further teaching? I need to monitor for signs of infection while on my medications. It's okay to skip my physical therapy sessions if I feel good. I should report any new joint pain to my healthcare provider. I can expect periods of exacerbation and remission.
Okay, so people with rheumatoid arthritis often take medications that suppress their immune system.
Right.
So monitoring for signs of infection is really important.
Yeah.
Reporting new joint pain is also essential because it could mean there's a flare or a new joint's becoming involved. And the disease is characterized by periods of flares and remissions, so that's accurate.
Right.
But skipping physical therapy, even if you feel good, that's not a good idea.
You are right. Consistency is key.
Consistency is key.
What is the role of occupational therapy in managing osteoarthritis? To provide medication management, to assist with pain management techniques, to modify activities of daily living, or to conduct surgical interventions?
Okay, so occupational therapists, they're all about helping people do those meaningful activities, right? So in osteoarthritis, I would say their focus is on modifying activities of daily living
Okay.
to make things easier on those joints.
You are right again.
Okay, good.
So they might recommend adaptive equipment or teach energy conservation techniques or even just ways to modify the home environment.
Yeah, just make things easier.
Yeah. True or false, the use of corticosteroids is recommended for long-term management of rheumatoid arthritis.
So corticosteroids, they're powerful, but they have a lot of side effects, especially if you take them long term.
So I'm going to say false.
You are correct.
Yeah.
They're good for short term.
Yeah, short.
Like when you're having a flare.
Yeah, to kind of calm things down.
But not something you want to be on long term.
Right.
Which joint conditions are characterized by joint swelling and tenderness? Osteoporosis, osteoarthritis, rheumatoid arthritis, gout.
Okay, so osteoporosis is more about weak bones, not inflamed joints.
Right.
But osteoarthritis, rheumatoid arthritis, and gout, those can all cause joint swelling and tenderness.
Yes. You are right. So those are all kind of those inflammatory conditions.
Yeah.
Okay, true or false? Osteoporosis has no observable symptoms until a fracture occurs.
So we talk about it being a silent disease, but I think there can be some subtle signs like back pain, loss of height, even before a fracture.
You are right. It's not always completely silent.
Okay.
So it's kind of like pay attention to what your body's telling you.
Yeah, those little whispers.
Yeah.
Which of the following is a common complication of hip fractures in the elderly? Hemorrhage, osteomyelitis, pneumonia, all of the above.
Okay. So hip fracture, serious injury, especially in older adults.
Yeah.
So there's always a risk of bleeding. So hemorrhage is a concern. And anytime you have a break in the skin, there's a risk of infection, including bone infections.
Right.
And then immobility after a hip fracture increases the risk of things like pneumonia.
Yeah, so all of the above.
All of the above.
A patient is prescribed an NAID for osteoarthritis. What should the nurse monitor for? Gastrointestinal bleeding, liver function tests, renal function, or cardiac rhythm.
So NSAIs can cause GI issues.
Yes.
Like ulcers and bleeding. So that's definitely something to watch for.
Yeah.
And then they can also affect kidney function.
Okay.
So renal function is also important.
Yeah, those are the two big ones.
Yeah.
The liver and the heart, we don't worry about those quite as much.
Yeah, not so much.
True or false, physical activity should be avoided in patients with rheumatoid arthritis.
That's false.
Yes.
We want to keep those joints moving.
Yeah.
It helps with mobility, strength, overall fitness.
It's about finding that balance.
That balance.
Yeah.
But yeah, for sure. Keep moving.
Which patient education point is essential regarding the use of calcitonin for osteoporosis? It should be taken in the morning. It should be administered via intranasal route. It has no side effects. or it is a first-line treatment for osteoporosis.
Okay, I know calcitonin is a hormone involved in calcium regulation, but I'm not too familiar with its use in osteoporosis.
Okay.
So I don't think when you take it is as important as, like, how you take it.
Okay.
And no medication is completely free of side effects, so that can't be right.
Right.
And whether it's first line or not, I'm not really sure.
Okay, so the key point here is that it's administered via intranasal route.
So it's like a nasal spray.
Exactly.
Okay.
Which of the following is not a characteristic of rheumatoid arthritis? Asymmetrical joint involvement, morning stiffness, presence of systemic symptoms, synovial membrane inflammation.
So we know rheumatoid arthritis is symmetrical. It affects both sides of the body. So the answer has to be asymmetrical joint involvement.
You are absolutely right.
All right.
True or false, weight-bearing exercises can help improve bone density in patients with osteoporosis.
That's true. We talked about this before. You want to put that stress on the bones.
Yeah.
So it makes stronger.
Exactly. It's like giving them a workout.
Yeah, exactly.
All right. Which nursing intervention is most appropriate for a patient experiencing a flare-up of rheumatoid arthritis? Heat application to the affected joints, cold application to the affected joints, restricting movement of the joints, or encouraging vigorous exercise.
Okay, so during a flare-up, you've got that inflammation, and cold helps to reduce inflammation.
Yeah.
So I'm going to go with cold application.
You are absolutely right.
Okay.
Cold is your friend during a flare-up.
It's like putting ice on a sprained ankle.
Exactly. It's that same principle.
Oh,
Which laboratory test is commonly used to assess inflammation in rheumatoid arthritis? Erythrocyte sedimentation rate, ESR, complete blood count, C2C, liver function tests, or urinalysis.
Okay, erythrocyte sedimentation rate, or ESR. That measures how quickly red blood cells settle in a test tube. And inflammation can actually cause those red blood cells to clump together and settle faster.
Yeah.
So the answer is ESR.
You are correct.
Yes.
The ESR, along with C-reactive protein, those are the two big ones we look at to assess inflammation.
It's so cool how a simple blood test can tell us so much.
It is. It really is.
Yeah.
Okay, so let's switch gears back to osteoarthritis for a second.
Okay.
What is a key risk factor for developing osteoarthritis? Family history, high calcium intake, regular exercise, or male gender?
Okay, so high calcium and exercise, those are good for your joints.
Yeah.
Men can get osteoarthritis, but I think women are more at risk, especially after menopause.
Right.
So I'm going to say family history.
You are absolutely right. So if your parents or your siblings have osteoarthritis, you're at higher risk.
Yeah.
It's just one of those things, that our genes can play a role in.
Genetics, they're tricky.
Yeah, for sure.
So
True or false? Bisphosphonates can cause gastrointestinal side effects.
That's true.
Yes.
They can be hard on the stomach, causing like irritation and ulcers.
Yeah, that's definitely something to watch out for.
For sure.
Okay, in patients with rheumatoid arthritis, which of the following joint deformities might you observe? Ulnar drift, Heberden's nodes, swan neck deformity, Bouchard's nodes.
Okay, so ulnar drift, where the fingers kind of deviate towards the pinky side, and swan neck deformity. I remember those as being characteristic of rheumatoid arthritis.
Yes.
Heberden's and Bouchard's nodes, I think those are more osteoarthritis.
You are correct.
Okay.
True or false, osteoporosis can only be treated with medication.
That's false.
Yes.
Medications can help, but lifestyle changes are so important.
Yes. They're the foundation. Which assessment finding would be most indicative of advanced osteoarthritis? Warmth and redness around the joint, crepitus on movement, high levels of joint mobility, or muscle atrophy.
Okay, so warmth and redness, that suggests inflammation, but it's not necessarily specific to, like, advanced disease.
Right.
Crepitus is common, but again, you can have that early on.
Yeah.
High levels of joint mobility wouldn't make sense.
Right, because things are getting
stiff.
Yeah.
Yeah, so I think it has to be muscle atrophy.
You are absolutely right.
Yes.
Well, researchers are always looking for new ways to help people living with these conditions.
Yeah, sure.
So, think gene therapy, stem cell research.
Wow.
Personalized medicine, all that.
It's like science fiction.
It is. It's
like coming reality.
Yeah.
That's pretty amazing.
Imagine being able to target the genes that are causing these problems or
regenerating cartilage.
Yes.
With stem cells.
It's incredible.
It's amazing. It gives me so much hope for the future.
Me too. And it's not just those kind of high-tech solutions.
Yeah.
There's this growing emphasis on prevention.
Right.
And early intervention.
Yeah, so catching things early.
Yeah, like how can we,
Stop it before it even starts.
yeah, like stop the problem before it even becomes a problem.
Exactly.
So promoting, healthy lifestyles from childhood.
Yeah, like building those good habits early.
Yeah, getting enough calcium, vitamin D, all that.
Yeah, that's huge.
And then for people who are already diagnosed, starting treatment early
Right.
can make such a difference.
Absolutely. Yeah.
So it's really about kind of empowering people to,
Take control of their health.
to take control of their health, to be informed.
Yeah, knowledge is power.
Yeah.
Absolutely.
I think you really hit on something important earlier when you were talking about like advocating for policies that kind of, support healthy aging and address like those social determinants of health.
Because those can really contribute to those disparities.
Yes.
And outcomes.
So it's not just about, the individual level.
Right.
It's about looking at kind of the bigger picture.
The bigger picture.
Yeah.
That's
this
it.
is like we need everybody working together.
Yeah, we all have a role to play.
Yeah, to really make a difference.
To create a future where, like, these conditions don't hold people back.
Yeah, exactly.
Everyone deserves to live a long and healthy life.
I love that.
Yeah.
Well, I think on that very hopeful note,
Yeah.
we've reached the end of our deep dive.
Wow, what a journey.
It has been.
I feel like I've learned so much.
I'm so glad.
I'm ready for that NCLEX.
Yes, you are.
Thank you so much for, guiding me through all this.
It's been my pleasure, honestly. It's been so fun to, explore these topics with you.
It's been great. Those NCLEX questions were really helpful.
Oh, I'm so glad.
Yeah, it made me realize that I actually know more than I thought.
And that's the goal.
Yeah, for sure.
To kind of, get you thinking.
Yeah.
And applying that knowledge.
It was great.
So remember, this is just the beginning.
It is. The journey continues.
Yeah. Keep asking questions.
Will do.
Keep learning.
I'm excited to.
Yeah. And thank you for joining us on the deep dive.
Thanks for having me.
We hope you've enjoyed exploring this fascinating world of the musculoskeletal system.
It is fascinating.
And until next time, keep diving deep.